Thank you for joining us for today's webinar, Beyond the Images, with MSK Radiologist Dr. Donna D'Alessio. My name is Hannah Belisle, and I'm a member of the Memorial Sloan Kettering development team. We're excited to share today's presentation to kickstart our fall webinar series that's hosted by the Development Office. Today's presentation will be followed by a brief Q&A featuring questions received in advance. After the webinar, this recording, as well as previous ones, will be available for you to revisit and share online. I'm honored now to introduce breast cancer radiologist Dr. Donna D'Alessio. Dr. D'Alessio is a faculty member of the Breast Imaging Service at Memorial Sloan Kettering Cancer Center in New York, where she serves as the director of the Breast Imaging Interventional Program. Dr. D'Alessio uses innovative technologies to detect and manage breast cancer in patients. She also conducts research that explores outcomes in patients undergoing multimodality, image-guided breast interventional procedures. Dr. D'Alessio received her undergraduate degree from Emory University and her medical degree cum laude from the State University of New York Downstate Medical Center. She completed her residency in diagnostic radiology at Weill Cornell Medical Center, New York Presbyterian Hospital in New York, and a fellowship in breast imaging at Stanford University Medical Center. Dr. D'Alessio, thank you so much for speaking with us today. We're excited to have you.
Thank you, Hannah. Welcome, everyone. I'm going to talk about breast cancer screening and what happens beyond the images. So a brief overview, I'm going to be talking about breast cancer in general, so we have an idea of what we are looking for, the risk factors associated with breast cancer, who we are at Memorial Sloan Kettering that participates in looking for this disease, what we do, why we do it, and how we do it. And then I'm going to talk about where we are going with new techniques for screening. This is a slide demonstrating the anatomy of the breast, and this black and white image is similar to what we look at on a mammogram. So we see the breast tissue, a part of the pectoralis muscle. We do not see the microscopic level. However, we're looking at the anatomy to see if there are changes that may indicate the presence of cancer. This is an example of how cancer develops. So normal tissue, normal breast tissue, is surrounded in an environment which keeps tumors in check. So there are multiple factors that influence how the cells change, and in a steady environment, these cells maintain a normal growth pattern. In cancer-promoting environments, there are forces that enable tumors to grow. There are changes in the surrounding tissue, or what we call the extracellular matrix, and there are cancer-associated fibroblasts and other cells that recruit blood vessels to cause the tumor to grow. On the bottom of this slide, you can see a normal duct where it's very smooth and all the cells look very, very identical. The next phase, typically in the development of a cancer, has to do with changes in the cell that may be hyperplastic. That's typical for changes that are related to cellular development. In this area, you can see that they're no longer contiguous and similar. They start to change. Intraductal hyperplasia with atypia is a change in the pattern of the cells that is greater than what we see in the first. When these cells fill the duct and become markedly abnormal, we develop an area internal to the duct, which is called intraductal carcinoma in situ, or DCIS. And this is the earliest form of breast cancer that we can detect with mammography. Invasive cancers break through this single layer outside of the duct. The risk factors for breast cancer are, the number one risk factor is just being female. As we increase with age, we can increase our risk of developing breast cancer. Patients with a family history of breast or ovarian cancer are also at greater risk for developing the disease. Patients with a personal history of breast cancer or have had a prior biopsy with what we consider to be high-risk lesions, which may be an indicator of precancerous cells, are also at greater risk. Patients who had thoracic radiation treatment for other malignancies, like Hodgkin's lymphoma, are at a greater risk for developing breast cancer. Hormone replacement therapy and lifetime menstrual cycles related to estrogens also promote the development of breast cancer in women. Breast density is also an individual factor that can affect a woman's risk for breast cancer, as well as other genetically predisposed diseases. Again, the number one risk factor for developing breast cancer is being female, and most patients who develop breast cancer do not have any unusual risk factors. So, who are we? At Memorial Sloan Kettering, there are a number of people involved with caring for patients as we screen for breast cancer. So this is Dr. Elizabeth Morris, the service chief for the breast imaging department in the Department of Radiology. And a number of doctors, which we call radiologists, are the ones who interpret the images that are taken by technologists. This is an image of one of our technologists doing a mammogram. They're responsible for getting adequate images so that we can be sure that we're looking at all the breast tissue that we can get on a picture. Here's an example of how we work together. We're a team here. This is Dr. Sung, one of our radiologists, and our tech supervisor, Pauline Turner. So what do we do? What are we looking for, and how do we find it? Breast cancer screening can often involve multiple modalities. So we start typically, for everyone, with a mammogram, which is an X-ray of the breast. Some patients need ultrasounds to help us distinguish areas in the breast noted on mammography to determine whether there are solid or cystic masses in the breast. And furthermore, patients may undergo MRI examinations, which is a vascular study which helps us know where tumors may potentially be growing. We put all of this information together with the mammogram, an MRI, or an ultrasound to help us to distinguish what is developing in the breast. This is an example of a mammogram with an abnormal mass in this area of the breast, which correlates to another area on a different image in a different projection, and is demonstrated by evaluation with ultrasound. Taking all of this information into account allows us to examine the patient from the inside out. So once we have all of the information, we can assign a sort of category or risk related to the imaging findings. Most often, patients get a normal mammogram report, which indicates that the patient is safe to come back in 1 year. Some patients may be asked to come back in a shorter interval just to be sure that the images are stable. Patients who are recommended for biopsy are given a letter or an interpretation that is considered suspicious that does not necessarily mean that there is cancer present. Some patients undergoing treatment for breast cancer have a known cancer, and there is an assigned level for this area as well. In some patients, we just need more information. The pictures that we have do not necessarily tell the whole story, and some more information may be needed. When patients have suspicious findings on imaging, we will recommend a biopsy. We use the images to help us guide the sampling. Biopsy is when we take samples of tissue to make a diagnosis. Radiologists like myself do image-guided procedures. Some procedures only involve a small needle, like one that would be used to take blood, which is considered to be a fine needle aspiration. Most often, we perform core needle biopsies, which help us get tissue samples adequate enough for a pathologist to make a diagnosis. And that is the goal of doing the biopsy. It's not necessarily to prove that what we see is cancer, but to make sure that it isn't. We can make further recommendations and referrals based on the results of the tissue diagnosis after the pathologist performs tests necessary to exclude the presence of cancer. We can do X-ray guided biopsies, which are called stereotactic biopsies, ultrasound guided biopsies with the device that I showed you on the prior image, or MRI guided biopsies. All of these techniques allow us to see what we thought may be suspicious and allows us to sample it adequately. Now that that is covered, I'm going to talk to you about why we screen for breast cancer. And when we talk about screening, we're talking about patients who are completely asymptomatic. That means they don't feel anything or have symptoms of any disease. Screening for breast cancer is important because over 40,000 women are expected to die of breast cancer in 2018, and it is the leading cause of non-preventable cancer death among these women. The lifetime risk for women for breast cancer is 1 in 8, or 12%. And it is often the case that many patients who come in for their screening mammograms are sitting next to someone who has had the disease. And approximately 800 women per day are diagnosed with breast cancer in the United States. This slide is from the American Cancer Society, and it shows that the most common cancer in women is breast cancer, which is another reason why it's important to screen and have a test that helps us detect the disease as early as we can, and that is screening. As I mentioned earlier, the risk of developing breast cancer is 1 in 8 for women. So how do we screen? We screen with mammography. Mammography is the only modality that has been proven to save lives. It is the single best modality for population-based screening, meaning women who are asymptomatic starting at age 40 should come in for their annual screening mammograms because it has been proven that we can find cancer as earliest doing this process. It's related to early detection. So cancers that are found early are much easier to treat and can undergo better therapy. And anything that we do in addition to mammography is supplemental. It is not instead of screening mammography. So when you hear about other modalities like ultrasound or MRI for screening, it's usually case specific and in addition to a regular mammogram. These are just images of a 2D mammogram, which shows the presence of cancer in patients who are asymptomatic, meaning they would not necessarily know that cancer is present in the breast. While we know and talk about the benefits of screening mammography, we do talk about what we consider potential harms. And harms is a word I would take putting it in context. So what we're talking about are false negative exams or exams that are interpreted as normal, however, the cancer is present. So when we talk about interval cancers, we're talking about between annual mammograms. So a person who has a negative mammogram 1 year and comes back within the interval of that year and is found to have cancer. A false positive exam is an exam where we find an abnormality that is not cancer. And most often that is associated with patient anxiety when we call back patients for images or recommend a biopsy that does not prove cancer. There's a potential for overdiagnosis, which is defined as finding a cancer that may not necessarily develop into one of clinical significance or one that is likely to lead to death. Patient anxiety and discomfort is also a potential harm of screening mammography. And radiation exposure or radiation-induced secondary cancers, which are of minimal risk in terms of the benefit of screening mammography. Mammography is not perfect. It has some limitations, and most of it is related to the sensitivity of the exam, meaning how well we can find the cancer, is related to breast density. And if you look here, you can see that this is a mostly fatty breast, and this is an extremely dense breast. And cancer is white when we look at it on a mammogram. So we're looking for something white on white in a dense breast. It's much more difficult to find than in something that is white on black in a patient who has a predominantly fatty breast. So you can see here, as the density increases, it's much more difficult to find cancer. So false positives, suggesting that there is a presence of an abnormality when there is not one, is a limitation of mammography. And when we put this in context, of 1,000 women screened, 10% will be recalled to come back for additional imaging, 2.5% will be asked to come back in 6 months, and 1.9% will be recommended for biopsy. And of those women, 32% will have breast cancer. When we talk about overdiagnosis, we're talking about cancers that are detected but may not be lethal. So this is where screening leads to diagnosis of cancer that would never be clinically evident, meaning you would never feel it or it would never cause any symptoms or death. The true extent of overdiagnosis is impossible to determine unless we don't treat the cancers that are found, and we have not planned to do that. Overdiagnosis or overtreatment. When we talk about this, we're talking about, are we more aggressively treating cancers that would not necessarily be lethal, or is it a problem just that we're detecting them too early? So when I talked about the limitation of mammography, I talked about breast density and how it decreases the sensitivity of the exam. And that is well known, as you are given an indicator in your letters when you leave from a mammogram about your breast density. And there has been breast density legislation in multiple states which require the radiologist to let the patients know if they have dense breast. So the shortcomings of mammography have led to the passage of these laws in many states. However, there are no results of new data or clinical trial that this is beneficial to the patients. And the laws require that we tell patients if they have dense breast and if they may benefit from supplemental screening in addition to the mammogram. But the type of supplemental screening is not specified. This is a map of the states which have passed or enacted a law that requires notification of patients of their breast density. And you can see the majority of the states require this or are working on the bill. So the pink have enacted laws, the red have introduced a bill, and those with a black star are those states that offer coverage with insurance for supplemental screening. And when we're talking about breast density, we want to know how many patients in the population actually have dense breasts. And if you look at this chart, you can see that over half are considered dense. So 10% are extremely dense, or the widest of the mammogram, and 40% are heterogeneously dense. So we're talking about half of the population of women who get screening mammograms have dense breasts. So what is the significance? The significance is that increased breast density decreases mammographic sensitivity, meaning it makes it harder to find cancer because the white breast tissue is masking the white cancer. And this is just what we see on the mammogram. And the magnitude of that depends on the patient's age. Younger patients most often have dense breasts, the density or how extreme it is, and the number of modalities used in addition to mammography. And it is a major impetus for supplemental screening modalities. Does breast density increase breast cancer risk, and is there a significance of that? For patients with heterogeneously dense breasts, there is a 1.2 times greater than average chance of developing breast cancer, and those women with extremely dense breasts are at a 2 times greater risk than the average woman. And that is equal to a woman with a first-degree relative with unilateral postmenopausal breast cancer, meaning that is equivalent to someone who has a positive family of breast cancer in these situations. But the masking effect of breast density is of greater import than the increased risk associated with breast density alone. So younger women with dense breast tissue have a mammographic sensitivity of only about 50%, and they are often patients who return with an interval cancer because the cancer is impossible to detect, and they may present with larger cancers at the time of presentation related to the fact that it is obscured during their annual mammograms. So how do we tailor screening to individual patients? And what are our trends and what are we working to do? And we're really working to sort of personalize this to a greater extent. So supplementary screening of the general population of women with dense breasts remains controversial. There are benefits versus the potential drawbacks. Some of the tools we use for supplemental screening include breast ultrasound, digital breast tomosynthesis, breast MRI, and contrast-enhanced mammography. All of these I will speak about. Whole breast screening ultrasound is a supplemental screening tool. It is what we default to when we offer supplemental screening to women with dense breasts, mostly because it is inexpensive, widely available, well tolerated, does not involve radiation, and does not depend on breast density the way mammography does. So it is a good tool to help us to further screen patients with dense breasts. The advantages are they can find 2 to 3 mammographically occult cancers per 1,000 women screened. So for every 1,000 women screened with additional supplemental whole breast screening ultrasound, we can find cancers that would not be evident on the mammogram. And these cancers typically are very, very small and have not metastasized to the lymph nodes. So this is an example of a heterogeneously dense breast on a mammogram, which was read as normal and interpreted as normal because there is no cancer obvious on the images. And this is a screening breast ultrasound exam, which shows what we call a mammographically occult cancer. This is a suspicious mass associated with increased blood flow and indicative of biopsy-proven cancer. So whole breast screening ultrasound has been shown to increase the cancer detection rate compared with mammography alone. However, there are disadvantages as a supplemental tool. There is a greater chance that there will be an increased number of benign biopsies compared with mammography, meaning we see something on the screening ultrasound that does not end up being cancer, but has been biopsied. And there's a much higher rate of recommendation for short interval follow-up or having you come back in 6 months rather than a year. It is a real-time exam that is technically dependent on the person performing the exam, and it can be very time-consuming. So what about digital breast tomosynthesis, or 3D mammography? This too is a supplemental tool and was FDA approved in 2011 to be used in conjunction with a 2D mammogram, or what we consider to be a standard mammogram. It involves rotating an X-ray tube in a series of low-dose images at different angles to allow us to unmask the effect that we see on a regular 2D mammogram. The total dose of a digital breast tomosynthesis exam is twice that of a full-field digital mammogram or the regular 2D mammogram. In addition, the breast remains in compression similar to a regular 2D mammogram. This is an example of a standard 2D mammogram. And if we take one view of that 2D mammogram and we do a tomosynthesis exam, You can see what we can't see the cancer on the 2D mammogram, but here the cancer is unmasked by slicing through it. I'll show it again. By slicing through the images, we can see the cancer here, which is obscured or masked on the regular mammogram. So tomosynthesis addresses some of the limitations of conventional mammography. 2D mammogram, the breast is a 3D structure viewed as a 2D image, meaning with compression, we are looking at something that would normally be space occupying and compressing it into a 2D image. The false negative 2D mammogram is related to the overlap of normal breast tissue that mimics suspicious findings, prompting additional imaging and possibly biopsy, meaning masking the cancer. A false negative exam is one that is interpreted as normal because the overlying normal breast tissue obscures or masks the malignant lesions, preventing detection. And tomosynthesis can decrease the number of callbacks or improved cancer detection and improves margin assessment when we're talking about the suspicious appearance of a lesion on a mammogram. Does tomosynthesis count as a supplemental screening tool for mammography, or is it just a replacement for mammography? With whole breast ultrasound, this detects 2 to 3 cancers per 1,000 women, and all of those studies that have evaluated whole breast screening ultrasound as a supplemental tool has been compared to 2D mammogram. Digital breast tomosynthesis detects 1 to 2 cancers per 1,000 women. So do women who have tomosynthesis benefit from a screening breast ultrasound? We consider digital breast tomosynthesis a slightly better mammogram, and it is becoming the standard or replacing 2D full-field digital mammograms, but it is less effective in women with extremely dense breasts. The current standard for screening for average to intermediate women with dense breasts is a 2D full-field digital mammogram or digital breast tomosynthesis supplemented with whole breast screening ultrasound. So vascular-based imaging includes breast MRI and contrast-enhanced digital mammography. Breast MRI is an anatomic and physiologic image, meaning we can see the anatomy of the breast tissue, but we're also talking about where the blood flow is going. It detects enhancing tumor vascularity after the administration of intravenous contrast. The tumor vascularity may be detected before a discrete mass is present, meaning before any anatomical changes are seen on a mammogram. And breast MRI demonstrates cancers at an earlier stage in high-risk women who are screened yearly with MRI compared with those screened with mammography alone. And this is particular for women who are at greater risk for the disease. MRI improves the overall survival in the population of high-risk women. The American Cancer Society guidelines for breast cancer screening with MRI as an adjunct or an addition to mammography is based on evidence. Annual screening MRIs are recommended for patients who are documented to have a BRCA 1 or 2 genetic mutation, patients who are untested for the genetic mutation who have a first-degree relative with the BRCA gene, or who are at a lifetime risk of 20% or greater, defined by particular risk factor assessments. The American Cancer Society guidelines for annual screening with breast MRI is based on expert consensus opinion, and it also extends to those patients who receive chest irradiation between the ages of 10 and 30, patients with genetic syndromes, including Li-Fraumeni or Cowden's disease. There is insufficient evidence to recommend for or against screening with MRI in patients who are at intermediate risk or at risk 15 to 20%, patients who have had prior biopsies that yielded high-risk lesions, patients with dense breast on mammograms, or patients with a personal history of breast cancer. There is insufficient evidence to recommend for or against, and this is an individualized choice. For breast cancer screening in women at higher than average risk, the recommendations from the American College of Radiology includes those women who have a personal history of breast cancer and dense breasts, a personal history of breast cancer diagnosed less than age 50, and to be considered if a personal history of breast cancer without dense breasts or diagnosed after age 50, or with a history of atypical lesions or high-risk lesions that may increase their risk. This is an example of a 49-year-old woman who carries the BRCA gene and who came in for routine screening, and the mammogram is interpreted as normal. There is no evidence of mammographically evident cancer. On the MRI, with enhancement, and you can see the blood vessels on this 3D image, which is the purpose of this vascular study, you can see the breast cancer, which was obscured on the mammogram. The sensitivity of breast MRI is 98%, meaning it It is successful in detecting breast cancer, 98%. It is the gold standard for breast cancer detection, and it does not involve radiation. However, its use is limited to a very small subset of high-risk women in the screening setting. Historically, it is not used for average to intermediate risk women because it is time-consuming, expensive, and it is not for everyone. Patients with claustrophobia or anxiety, pacemakers, or allergy may not be able to tolerate the exam, and therefore it is not used in population-based screening and simply reserved for those at high risk. Another vascular-based imaging technique is contrast-enhanced digital mammography. Contrast-enhanced digital mammography is based on the physiologic detection of cancer similar to MRI. Contrast travels to sites of increased tumor vascularity, which is why we consider this to be a physiologic study. It is an alternate to MRI for patients who cannot undergo or tolerate breast MRI and who would benefit from a vascular study. There is improvement in the sensitivity, which is more likely to occur in women with dense breasts than women with fatty breasts, and it has been offered at Memorial Sloan Kettering since 2012. Here is an example of a routine screening mammogram, which obscures cancer in this woman with heterogeneously dense breasts. Here is the MRI, which shows the vessels again, and the tumor being enhanced by the contrast agent, which makes it more conspicuous. This is a contrast-enhanced digital mammogram, which shows similar findings, the vascular study, which shows evidence of a malignant tumor. Similarly, this is a 2D mammogram, which shows extremely dense breast tissue, which is obscuring a breast cancer. This is an MRI image, which shows the vascularity and the presence of malignant tumors in this portion of the breast. Similarly, in the contrast-enhanced mammogram, there is contrast, which travels to the tumor based on the vascularity. These two are obscured on the 2D mammogram. This is a woman with heterogeneously dense breasts who came in for routine screening mammogram, interpreted as normal. You can see that the cancer was obscured on the mammogram. On the contrast-enhanced digital mammogram, contrast shows and highlights the area of malignancy. This tumor is evident on ultrasound and biopsy proven to be cancer. Where are we going in the future? Cancer detection may be liquid biopsy. That's what we're considering as the future for breast cancer detection. Can we see it with ctDNA? This would be related to a blood test as opposed to imaging or biopsy. And this would be related to tumor tissue releasing through secretion, necrosis, and mostly apoptosis into the bloodstream, which may be detected by a blood test. Will this lead to early detection? And is this also having a similar problem with overdiagnosis? That is yet to be determined. So in conclusion, mammography is currently not enough for everyone, and there are small improvements in breast cancer screening with digital breast tomosynthesis and whole breast screening ultrasound. Vascular imaging, currently breast screening option in the near future, can we offer this to all women on a screening basis? However, MRI is limited access, and the cost may preclude using this in the screening setting other than those women who are at high risk. Can we do this better and more cost effective? Can we abbreviate the MRI to make it a shorter study and maybe more applicable to more women? That is where we are looking now. Contrast-enhanced digital mammography, there is not enough data to determine whether or not this can be used in screening, but that is an area of exploration in the future. And can we do liquid biopsies for screening in the future, and what will the limitations be for that? These are the areas that we are looking into here at Memorial Sloan Kettering as a team, with imaging and surgery and medical oncology to determine the best way to screen for breast cancer. Thank you for joining us today.
Thank you so much, Dr. D'Alessio. This has been fascinating and so important. During registration, we gave participants the opportunity to ask questions and submit questions, and we received more than our time today permits. So thank you to everyone who shared questions. Many of the questions we received were related to specific diagnoses, and we do encourage anyone listening or anyone who submitted those questions to discuss personal questions with your physician, and we do have time for a few of the more general questions, so I'll jump right in. How, in general, has the landscape of breast cancer prevention and screening changed over time?
Thank you, Hannah. For the most part, even today, mammography is the only tool that has been proven to be to save lives, and that is related to its implementation in a general screening population in the early 1990s, where there is about a 40% reduction in breast cancer deaths related to screening. So we've started with mammography and really only built on that. And we still need this tool. And anything that we do in addition to that is really supplemental. Nothing else has been proven to do the same thing. But over time, we've added more to get better. And we've taken into account expanding what we know about the tumor progression from changes in the vascular and environment of the cells to those changes that would be detected by anatomy on mammography. So we've expanded to look with increasing sort of devices and technology like MRI and whole breast screening ultrasound and digital breast tomosynthesis to improve upon what we already have, which is mammography.
We learned, or we know, and you made very clear that breast cancer affects more women than men, and women are certainly at greatest risk. Can you speak a little bit to breast cancer screening and prevention in male populations?
We typically don't screen male patients for breast cancer unless they have a genetic predisposition to the disease, including the BRCA gene mutation. Those patients may undergo screening, but it would be specific to a high-risk population.
How can patients and even non-patients learn about their risk for developing breast cancer? Are there options to personalize screenings and other preventative measures to meet individual needs?
Yes, patients and even non-patients can learn about their risk. There are many available tools, even accessible to you and the population, and that can be found with risk assessment tools. Even on the American Cancer Society website, they can talk about different risk assessment models. And we have a high-risk clinic at Memorial Sloan Kettering, which addresses these specific issues, and information about that is available on the website. And the point of these is to determine with a number or a numerical value your lifetime risk of developing the disease, taking into account a number of factors: family history, personal history, genetic predispositions, putting all that information together in a mathematical model to give you a number and to tell you what your risk is. That will guide what additional supplemental tools you may benefit from in addition to mammography.
What are some of the educational outreach programs that you're involved with, and can you speak to how they impact the community?
Recently, I've become involved with the City University of New York in outreach programs up in the Harlem area and with the medical school there, giving community lectures. We offer similar lectures about this topic to promote and encourage women to participate in annual screening mammography because we know it saves lives. So informing patients and giving them information about how this will benefit them is really our goal. And we do speak at multiple events throughout the community to guide women and to make them less scared, basically, about participating in a screening program and getting their mammograms annually.
The last question I'll ask, you covered a lot of ground. So if for anyone listening in, what is the top one or two things that you hope that they would walk away from today's presentation knowing and possibly sharing with a loved one?
Don't be afraid of mammograms. Mammograms have been shown to save lives. And so getting your annual mammogram really helps us as the doctors find the cancers at the earliest possible time where it can be treated less aggressively. And that's really the goal of mammograms. So I would hope that the women and the men just take away that it's an important process that will keep them healthy.
Thank you so much, Dr. D'Alessio, for taking the time to be with us today and for engaging us on this important and incredibly timely topic. And thank you to all of our listeners. We hope you found the presentation valuable. If you're interested in learning more about cancer care and research, we encourage you to keep an eye out for emails and other updates from MSK. You'll receive a follow-up email linking you to a survey about your experience on today's webinar. We encourage you to take the time to give us your feedback because it helps us give you more meaningful content in the future. Thanks again for joining us and have a wonderful rest of your afternoon.